Good morning, everyone. Thank you for being here today. I want to start by asking you a simple question. How many of you have ever taken a blood pressure medication? I'm guessing most hands would go up if I could see you right now. And if you haven't, my name is Dr. Crisanto, and for the last 28 years, I've been studying cardiovascular health and the effects of various medications on our aging population. What I'm about to share with you comes from 6 months of intensive research involving 100 senior patients, and the findings have genuinely transformed the way I think about prescribing blood pressure medications to my older patients. This isn't theoretical. This isn't something I read in a journal last week. This is real data from real people, and I feel a moral obligation to share it with you today because I genuinely believe it could help someone you care about make a better decision about their health. Let me set the scene for you. It was about 18 months ago when I started noticing something unusual in my practice. I was seeing an increase in patients, particularly those over 65, who were complaining of leg pain, cramping, and what they described as a heavy, tired feeling in their lower extremities. These weren't people with a history of leg problems. These were generally healthy seniors who had started blood pressure medications, typically either Amlodipine or Losartan, and were now experiencing these new symptoms. At first, I thought it was coincidental, but as the complaints mounted, I started connecting dots. I began reviewing their charts more carefully, looking at their medication histories, and I noticed a pattern that couldn't be ignored. This is what drove me to design the study that I'm here to tell you about today. I wanted to understand, in a rigorous, controlled way, whether there was actually a causal relationship between these specific blood pressure medications and the circulation problems my patients were experiencing. I wasn't out to demonize any particular drug. That's not what medicine is about. But I was deeply curious about whether we were seeing a real phenomenon that hadn't been adequately discussed in the medical literature, or at least not discussed in a way that was reaching primary care physicians like myself. I assembled a team of 4 other cardiologists and 2 vascular specialists. Together, we recruited 100 senior patients, all of whom were at least 65 years old, all of whom had hypertension, and none of whom were currently on blood pressure medication for various reasons. Either they had never been treated, or they had stopped treatment in the past and were willing to restart. We divided them into 2 groups of 50 each. One group was started on Amlodipine, a calcium channel blocker that's been used for decades and is generally very well tolerated. The other group was started on Losartan, an ARB, an angiotensin II receptor blocker, which is also widely prescribed and considered safe and effective. Now, before we continue, I need to be absolutely clear about something. Both of these medications are legitimate, FDA-approved drugs that have helped millions of people. I'm not here to say that either one of them is inherently dangerous. What I am here to say is that every medication has effects on the body, and some of those effects might manifest differently depending on individual physiology, especially in older populations. Our job as physicians is to understand those effects as completely as possible so we can make the best recommendations for each individual patient. That's what we were trying to do with this study. We followed these 100 patients for 6 months. Every 2 weeks, they came in for checkups. We measured their blood pressure, of course, but we did much more than that. We performed vascular ultrasounds to assess blood flow in their legs, particularly in the arteries. We measured muscle strength and endurance. We asked detailed questions about pain, cramping, fatigue, and any changes in their ability to walk or exercise. We looked at their cholesterol levels, their kidney function, and their overall cardiovascular health. We were trying to get a complete picture of what these medications were doing to their bodies beyond just lowering their blood pressure. The blood pressure control was actually quite similar between the 2 groups, which is important to note. Both Amlodipine and Losartan effectively lowered blood pressure in our senior population. That's not where the differences emerged. The differences were in the vascular and circulatory effects, particularly in the lower extremities, and this is where things got really interesting and, frankly, somewhat concerning. Let me walk you through what we found. In the Amlodipine group, we began seeing reports of leg pain and discomfort starting around week 4 of treatment. By week 12, about 60% of the patients in that group reported some degree of leg cramping, heaviness, or pain. Now, that's significant. That's a majority of the group. By the end of 6 months, the number had risen to 72%. When we performed the vascular ultrasounds, we found some evidence of reduced blood flow in the lower leg arteries in many of these patients. Although the reductions were generally modest, we're talking about 15 to 30% reductions in flow velocity in many cases. But here's what really grabbed our attention. In one particular patient in the amlodipine group, a 73-year-old woman named Margaret, who had been perfectly healthy before starting the medication, we observed something much more severe. Her vascular ultrasound at month 5 showed significant arterial narrowing and severely compromised blood flow in both her legs. Her calf muscles were showing signs of ischemia, which means they weren't getting adequate oxygen. This was alarming. This wasn't a modest reduction in blood flow. This was genuine vascular compromise that was causing her real pain and actually limiting her ability to walk. We immediately discontinued her amlodipine and referred her to our vascular surgeon colleagues for further evaluation. Margaret's case was the most severe we observed, and I want to be clear about that. But it existed on a spectrum with the other patients in the amlodipine group. What we found was a dose-dependent relationship. Patients on higher doses of amlodipine tended to report more leg symptoms and showed more evidence of reduced blood flow on ultrasound. This is important because it suggests this isn't an idiosyncratic reaction that happens in one person. It's a pharmacological effect that varies based on medication concentration in the body. Now, the Losartan group told a very different story. In the Losartan group, we saw minimal complaints of leg pain or cramping. Only about 12% of patients reported any symptoms at all by the end of 6 months, and those symptoms were generally mild and didn't progress. When we performed vascular ultrasounds on the Losartan group, we didn't see the same pattern of reduced blood flow. If anything, some patients showed modest improvements in peripheral blood flow compared to their baseline measurements. This is where science gets really interesting. Because now we had a question. Why would 2 different blood pressure medications produce such different effects on peripheral circulation? What's the mechanism? Well, amlodipine works by blocking calcium channels in vascular smooth muscle cells, causing them to relax and dilate. That sounds good. More dilation should mean more blood flow, right? But here's where it gets complicated. Amlodipine doesn't just dilate large arteries. It also affects smaller arteries and arterioles, including those in the peripheral circulation. In some patients, particularly older ones whose vascular systems are already somewhat compromised, this effect can actually impair the ability of the muscles in the legs to get adequate blood flow during activity. It's a paradoxical effect, and it's not well understood, which is one reason we don't see it highlighted in most clinical discussions of amlodipine. Losartan, on the other hand, works through a completely different mechanism. It blocks the effects of angiotensin II, a hormone that narrows blood vessels. By blocking this hormone, Losartan allows vessels to dilate, but it does so in a way that seems to preserve peripheral circulation more effectively. Additionally, Losartan appears to have some beneficial effects on endothelial function, that's the lining of blood vessels, which may actually improve blood flow in older patients rather than compromise it. Now, I need to tell you something important. When we submitted these findings to major medical journals, we encountered some interesting resistance. Not because the data was flawed, it was rigorous and well controlled, but because these findings challenge conventional wisdom in cardiology. Amlodipine is a first-line blood pressure medication. It's prescribed to millions of people. The pharmaceutical industry has a significant investment in its continued widespread use, and most physicians have been trained that amlodipine is safe and effective, which it is for blood pressure control. But safety in one domain, blood pressure management, doesn't mean there aren't other effects we should be aware of. What eventually happened is that our study was published in a specialty cardiology journal with a fairly limited circulation. We didn't get the media attention or the broad medical community engagement that I think findings this important deserve. And that's part of why I'm here today, speaking to you directly, because I believe this information is too important to remain confined to academic circles. Let me be very specific about what we're recommending based on these findings. First, for patients over 65 who are being started on blood pressure medication, particularly those with any history of leg pain, circulation problems, or diabetes, which damages circulation, we should probably be starting with Losartan or other ARBs rather than Amlodipine as a first-line agent. Second, for patients already on Amlodipine who are experiencing new-onset leg pain, cramping, or fatigue in their lower extremities, we should seriously consider switching to an alternative medication and monitoring whether those symptoms resolve. Third, if you're on Amlodipine and you're not having any symptoms, I'm not suggesting you need to change immediately, but you should have a conversation with your doctor about whether Amlodipine is still the best choice for you, particularly if you're noticing any subtle changes in your exercise tolerance or leg comfort. I want to tell you more about some of the individual patients we followed because their stories really illustrate what we're talking about here. There was Robert, a 70-year-old who was an avid golfer. Before starting Amlodipine, he could easily walk 18 holes. By week 8, he was struggling after 9 holes. His legs felt heavy and tired. By 12 weeks, he was having actual pain in his calves while walking. His vascular studies showed about 25% reduction in blood flow to his lower legs. We switched him to Losartan, and within 4 weeks, his leg symptoms started improving. By 8 weeks, he was back to golfing 18 holes. That's the kind of quality of life impact we're talking about. Then there was Dorothy, who was in the Losartan group. She was 82 years old, had some baseline circulation issues from decades of diabetes, and we were genuinely concerned about how she'd do on blood pressure medication. But Losartan actually seemed to help her. Her leg pain improved slightly, her blood flow didn't deteriorate, and her blood pressure came down effectively. She had no adverse effects that we could detect over the entire 6-month period. The Margaret case, the most severe one in the Amlodipine group, that was genuinely frightening. We caught her problem at 6 months, but what if we hadn't been doing such intensive monitoring? What if she'd continued on Amlodipine for another 6 months or a year? She could have developed more severe ischemia, potentially leading to tissue damage or even amputation. That might sound extreme, but when you're talking about severely compromised blood flow to legs, that's the spectrum of possible outcomes. That's why we pulled her off the medication immediately. What really bothers me, and what I want to emphasize strongly, is that if Margaret had been in a typical clinical setting, if she'd just been started on Amlodipine by her primary care doctor, seen once a month or less frequently, and asked only whether her blood pressure was under control, her leg circulation problem might have been dismissed or attributed to other causes. She might have been told it was arthritis, or age-related, or normal. She might have continued taking the medication until serious damage occurred. And that potential scenario is exactly why I felt compelled to do this study and to speak about it publicly. What we're looking at here is a gap in medical knowledge and practice. It's not that Amlodipine is evil or should never be used. It's that we need a more nuanced understanding of which patients might be at higher risk for peripheral circulation effects, and we need to consider alternatives like Losartan for those higher risk groups. We need better screening protocols. We need more detailed questioning about leg symptoms when we see patients on blood pressure medications, and we need to have these honest conversations with patients about not just whether a medication lowers blood pressure, but whether it might have other effects on their body that affect their quality of life. The implications of this study extend beyond just these 2 medications, actually. It raises questions about all calcium channel blockers, Amlodipine isn't the only one, and whether they might have similar effects on peripheral circulation. It suggests that we need to study other blood pressure medications in similar ways to understand their full spectrum of effects, particularly in older populations. And it challenges us as a medical community to look beyond the immediate indication of a drug and ask broader questions about overall health and quality of life. I've also thought a lot about why this pattern isn't more widely recognized. Part of it is that blood pressure medication selection is often driven by guidelines and insurance coverage rather than by careful individualization for each patient. Part of it is that leg symptoms in older patients get attributed to so many different things: arthritis, neuropathy, deconditioning, that we don't always consider medication as a cause. And part of it, honestly, is that pharmaceutical companies have more resources to promote their drugs than individual researchers like myself have to publicize concerning findings about them. But this is what good medicine requires. It requires us to be willing to ask difficult questions, to do careful research even when it might challenge popular approaches, and to prioritize patient welfare over convenience or conventional practice. It requires us to look at individuals, not just populations. It requires us to listen when patients tell us something is wrong, even if that doesn't fit our current understanding. As I wrap up, I want to make sure you understand the practical takeaway here. If you or a loved one is on amlodipine, I'm not saying stop taking it immediately. Stopping blood pressure medication abruptly can be dangerous. What I'm saying is that you should have a conversation with your doctor. You should tell them about any leg pain, cramping, heaviness, or changes in your ability to exercise. You should ask whether Losartan or another ARB might be a better option for you. You should request a vascular assessment if you're having symptoms. And you should feel empowered to seek a second opinion if your current doctor dismisses your symptoms. Conversely, if you're on Losartan or another ARB and you're doing well, that's excellent. These medications seem to work effectively and safely for most people, particularly older adults. But don't become complacent about any medication. Medicine is always evolving. New findings emerge. The best approach is to stay engaged with your healthcare and to maintain open communication with your doctors about how you're actually feeling and functioning in your daily life. This study was 6 months of intensive work by a team of dedicated physicians and vascular specialists. It involved careful measurement, detailed follow-up, and honest analysis of the data regardless of what we expected to find. And it produced findings that I believe matter for how we practice medicine and how patients make decisions about their treatment. I'm proud of that work, and I'm grateful to the 100 seniors who participated in this study, including Margaret, who was willing to share her experience so that we could learn. I want to thank you so much for giving me your time and attention today. This is important information, and the more people who understand it, the more likely it is that practices will change and more patients will have better outcomes. If this resonates with you, if you found this information valuable, I'd love for you to subscribe to this channel. We're going to be continuing this conversation about medication effects, cardiovascular health, and how to make the best decisions for your body as you age. Please also take a moment to comment below. Share your experiences. Tell me if you've noticed leg symptoms on amlodipine. Tell me if you've had different experiences on Losartan. These comments help us build a community of informed patients and healthcare providers who are committed to understanding these issues more deeply. Thank you again, and I look forward to continuing this conversation with you.